1, 2,
And review 70-year-old female receiving
got blood going.
blood.
Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's charter book.
300 please.
I'll keep your card again.
Pulse check. No pulse.
No more pulse.
Yeah. Where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Usually when we talk about a medical diagnosis in the hospital, there's this underlying expectation of precision. It feels like, I don't know, engineering.
Right, like it's a math problem.
Exactly. You break your arm, the patient goes down to radiology, and the x-ray comes back showing that jagged white line on the radius. And the attending just points to the screen and says, well, there it is. That's the problem.
It's completely binary. I mean, it's broken or it's not broken. You put a cast on it or you take them to the OR. It's clean, it's visual, and frankly, it's deeply comforting to the human brain to see it like that.
Yeah, we really like things to be categorized. But then you walk through the double doors of a psychiatric unit, or, you encounter a patient with a substance use disorder on a med-surg floor, and suddenly that x-ray machine is just useless.
Completely useless. You're looking at a diagnostic landscape that is incredibly mucky.
Right. I mean, you can't draw blood to instantly quantify a patient's level of denial.
Yeah.
You can't put a stethoscope to their chest to hear the deterioration of their coping mechanisms.
And yet, as a nurse, you are expected to assess and intervene with the exact same level of clinical precision as you would for a fractured bone.
Which is terrifying when you're new.
Oh, absolutely. Which is why understanding the pathophysiology, the real psychological underpinnings of substance use disorders, it isn't just some academic exercise. It is a daily survival skill on the floor.
And the sheer scale of these murky waters is what gets me. Like, when you look at the epidemiological data, the numbers just hit you like a physical weight.
They're staggering.
We are talking about 29.5 million people over the age of 12 in the United States currently living with an alcohol use disorder. And that includes nearly 900,000 adolescents between ages of 12 and 17.
Which represents a massive public health crisis, one that infiltrates every single medical specialty. You will not escape this just by avoiding the psych ward.
Yeah, you see it everywhere. And the opioid statistics are equally grim. The data shows we're seeing 300 deaths every single day in the U.S. strictly from opioid overdoses.
I always tell my students, if a commercial passenger jet fell out of the sky every single day, killing 300 people, the entire world would stop.
Seriously, there would be congressional hearings tomorrow.
Right. But this crisis happens quietly, just in living rooms and public restrooms day after day.
And it absolutely shatters families. I mean, the data points out that 8.7 million children, so that's like 1 in 8 kids in the U.S., are currently living with a parent who has an active substance use disorder.
It's heartbreaking, and it's why clinical competence in this area is non-negotiable.
So, to you, our listener, welcome to this deep dive. Whether you're prepping for your NCLEX next week, gearing up for your next clinical rotation, or just trying to wrap your head around how to safely care for these patients, we have a very specific mission today.
We are stepping into the roles of your psychiatric nursing mentors. That's the lens we're using today.
Exactly. We are taking this dense, incredibly critical landscape of substance use disorders and extracting the absolute highest yield material. We are bypassing the fluff.
Because when you are standing at the bedside of a patient whose airway is closing, or when you're staring down a board exam question with 4 answers that all look technically correct, you do not have time to second guess.
You really don't.
You need to know the core pathophysiology, the priority assessments, and the immediate life-saving interventions.
I like to think of this source material like a dense jungle. If you try to memorize every secondary characteristic, like every minor side effect of every obscure hallucinogen, you are going to get completely lost in the weeds.
You'll burn out before you even take the exam.
Right. So we are here with a machete to carve out a clear, safe, logical path for you. And we do that by focusing on the why.
The why is everything. If you understand why alcohol withdrawal can kill a patient, but opioid withdrawal usually just makes them wish they were dead, you won't need to rely on rote memorization.
The correct nursing action will just make logical sense based on the cellular biology.
Precisely. So to build that logic, we need to start with the 80-20 rule, the Pareto principle.
Our high-yield overview.
Exactly. Before we dive into the granular pathophysiology of individual disorders, you need a cheat sheet. This is the 20% of the clinical knowledge that will answer 80% of the questions you face, whether from a clinical instructor or on a standardized exam.
Okay, so if I'm walking onto the floor, my brain immediately prioritizes two heavyweights: alcohol use disorder, or AUD, and opioid use disorder, or OUD.
Those are the absolute must-know disorders. Yes, you will encounter cannabis hyperemesis, and you'll see patients high on synthetic cathinones, but alcohol and opioids dictate the flow of emergency medicine.
They're the ones causing the codes.
Exactly. They cause the most frequent and critically the most deadly medical emergencies. As a registered nurse, your primary directive above all else is patient safety.
Which means we need a non-negotiable mental list of lifesaver medications. Like if you wake up in the middle of the night, you should be able to recite these three.
Let's hear them.
First, benzodiazepines. These are your gold standard for managing alcohol withdrawal and preventing a patient from seizing to death.
Crucial. And the second?
Second is naloxone, universally known as Narcan. This is your immediate reversal agent for an opioid overdose.
Right. And the third is thiamine, vitamin B1, which we push for patients with severe alcohol use disorder to prevent irreversible permanent brain damage.
We will explore the exact receptor mechanics of those meds shortly, but alongside the pharmacology, you must lock in the must-know safety risks.
The biggest one being respiratory depression. That is the classic mechanism of death in opioid and barbiturate overdoses. The central nervous system becomes so profoundly depressed that the brainstem simply forgets to tell the lungs to expand.
Just totally forgets to breathe. And the flip side of that coin is the withdrawal. When you are sitting for your boards, the trap they set for you is assuming that all drug withdrawals are treated the exact same way.
And they are absolutely not.
Right. Withdrawing from heroin is agonizing. It involves vomiting, diarrhea, muscle cramps, profound dysphoria. But physiologically, the body usually survives it.
However, withdrawing from alcohol or barbiturates causes such a violent neurochemical rebound that it triggers lethal status epilepticus. Alcohol withdrawal is a medical emergency.
That distinction alone will save lives. You also need to internalize the must-know communication strategies, right?
Oh, absolutely. Psychiatric nursing requires a complete overhaul of how we naturally converse. You must be matter-of-fact, direct, and entirely non-judgmental.
You do not argue with the patient experiencing a delusion or deep denial.
Never. You also cannot allow them to externalize blame. If a patient says they only drink because their boss is demanding, you do not validate that excuse.
No enabling. You focus entirely on the client taking responsibility for their own actions in the here and now.
And rounding out our high-yield overview is the legal and ethical mandate, the impaired professional.
This one is huge on exams. If you suspect a colleague is diverting medications or practicing under the influence, you have a mandatory duty to report them to a nursing supervisor.
You do not confront them privately, ever.
Yeah.
This is heavily tested because it directly opposes our human instinct to protect our friends.
But in nursing, protecting a friend who is impaired means actively endangering patients.
Exactly. So, keeping that high-yield overview in our back pocket, let's wade into the deepest part of these waters. Let's look at alcohol use disorder.
Okay, the burning question I always had in nursing school was about the physiology of withdrawal. Like, why is it that something you can legally buy at the grocery store on a Tuesday afternoon can cause a withdrawal syndrome that literally stops your heart?
While withdrawing from a terrifying street drug like illicit fentanyl usually doesn't.
Right. It seems so counterintuitive.
To understand that, you have to look at the neurotransmitters. Specifically, you need to picture the seesaw relationship between GABA and glutamate in the brain.
Okay, a seesaw. So GABA is your primary inhibitory neurotransmitter. It slows things down, relaxes the muscles, reduces anxiety.
And glutamate is your primary excitatory neurotransmitter. It amps things up, keeps you alert, facilitates learning. In a perfectly healthy brain, these two are perfectly balanced.
But alcohol is a central nervous system depressant, so it acts like a massive thumb pressing down on the GABA side of the seesaw.
Exactly. It enhances the inhibitory effects, which is why a few drinks make people feel relaxed, slurs their speech, impairs their coordination.
But the brain is an incredibly adaptable organ, right? It senses this artificial depression and thinks, uh-oh, we're shutting down, I need to keep the lights on.
That's precisely what happens. So to compensate for the constant flood of alcohol, the brain drastically downregulates its GABA receptors, making them less sensitive, and massively upregulates its glutamate receptors.
It's pouring out excitatory chemicals just to fight the sedation.
I love the car analogy for this.
Oh, right. It's like driving a car with your foot slammed on the brake, which is the alcohol.
Right. And to keep the car moving at 60 miles an hour, the brain slams its other foot on the gas pedal, which is the glutamate.
Which sets the stage for disaster when the patient suddenly stops drinking. They take their foot off the brake, the alcohol is gone.
But the brain still has its foot pinned to the floorboard on the excitatory gas pedal.
Wow. So you suddenly have a massive, uninhibited flood of glutamate storming through a brain that has virtually no GABA defense left.
The central nervous system rebounds violently. That autonomic hyperactivity is the exact mechanism that causes the soaring blood pressure, the drenching sweats, the profound tremors, and ultimately, the lethal seizures.
The brain is literally misfiring itself to death.
That is the core pathophysiology. And when we map this to the nursing model, we also have to look at the risk factors that lead a patient to this point. It is not just a matter of core willpower.
Right. Research, particularly comprehensive twin and adoption studies, demonstrates that genetics account for roughly 50 to 60% of the variation in the causes of AUD.
More than half the risk is baked into your DNA before you ever take your first sip.
That's wild. There's a specific neurochemical vulnerability in the dopamine pathways, isn't there?
Yes. When anyone drinks a mood-altering substance, it stimulates the dopamine pathways in the limbic system, producing a positive reinforcement, a high.
But the critical difference lies in the internal alarm system. Like for the general population, after a drink or two, the brain registers the pleasant sensation, and an internal neurochemical feedback loop signals, okay, that is sufficient.
We can stop now. But patients with true AUD simply lack that internal alarm. They experience the initial dopamine rush, but the signal to stop never arrives.
So they drink until the external environment forces them to stop, or until they are completely intoxicated.
We also have to assess the environmental and cultural risk factors. Psychologically, severe inconsistency in parenting, poor role modeling, or an environment completely lacking in nurturing sets a foundation for maladaptive coping.
And socially, just the sheer availability and cultural normalization of alcohol play a massive role.
Cultural competence is a huge part of your assessment here, too.
Oh, for sure. For instance, we know there's a specific biological phenomenon linked to genetic variants for enzymes involved in alcohol metabolism, specifically an ALDH2 deficiency.
Right, which causes a severe flushing reaction, reddening of the face and neck, headaches, and nausea even after tiny amounts of alcohol.
And that's highly prevalent among people of Asian descent.
You also have to consider systemic historical trauma. When assessing Native American and Alaska Native populations, we see devastating rates of alcohol-related mortality.
Right. Alcohol use heavily contributes to the top causes of death in these demographics, like liver disease and motor vehicle accidents.
It requires a nursing approach that is deeply sensitive to systemic inequities and historical trauma, rather than just treating it as an isolated behavioral issue.
Okay, so when we're at the bedside looking at expected findings, we have to split them into acute intoxication versus long-term physiological damage.
Intoxication is the classic presentation. Impaired attention, unsteady gait, slurred speech. But then there are the blackouts.
A blackout is a fascinating and honestly terrifying neurological event. It is not passing out.
No, during a blackout, the patient is awake, ambulant, and interacting. They might be driving a car or having complex conversations.
But the alcohol has essentially shut down the hippocampus. The brain stops pressing the record button.
The patient continues to function with zero conscious awareness of their behavior and will have absolutely no memory of it the next day.
Wow. But let's look at the long-term physiological destruction. The systemic damage is catastrophic.
We see cardiac myopathy, where the heart muscle literally stretches and weakens. We see pancreatitis, hepatitis, and cirrhosis of the liver.
Which leads to a cytostat condition where the failing liver causes massive fluid accumulation in the peritoneal cavity. The abdomen swells up tight like a drum.
And we must talk about Wernicke-Korsakoff syndrome. This is a severe, debilitating neurological complication caused directly by a deficiency in vitamin B1 thiamine.
Because heavy alcohol users often substitute alcohol for food, right? Leading to profound malnutrition.
That and alcohol actively inflames the stomach lining, inhibiting the absorption of whatever thiamine they do actually consume.
So Wernicke encephalopathy is the acute, life-threatening phase. You will see a patient with acute confusion, abnormal eye movements like nystagmus, and a staggering, unsteady gait.
And if you do not push IV thiamine immediately, it progresses into Korsakoff psychosis,
which is chronic and largely irreversible. The hallmark is an inability to form new memories, coupled with confabulation.
And it is crucial to understand that confabulation is not lying. The patient is not trying to deceive you.
Their brain just has massive memory gaps, and it automatically fabricates logical-sounding stories to patch those holes. They genuinely believe the reality their broken brain is constructing.
Which brings up a physiological concept that often confuses students, the tolerance break.
Yeah, normally we think of tolerance as a patient needing more and more of a substance to achieve the same effect.
Right, the receptors downregulate, the liver enzymes ramp up, and they can drink a fifth of vodka and still walk a straight line.
But eventually, they hit a breaking point. After years of sustained abuse, the central nervous system becomes exhausted.
The receptor downregulation reaches its absolute limit. And critically, hepatic metabolism fails because the liver is scarred with cirrhosis.
So the tolerance break is when a chronic, heavy drinker suddenly becomes profoundly intoxicated off just 1 or 2 beers.
The metabolic machinery is utterly broken. The enzymes that used to process massive volumes of ethanol simply don't exist anymore. The alcohol hits a system that has zero capacity to clear it.
When you see a tolerance break, you're looking at end-stage physiological failure,
Right.
which transitions us perfectly to the priority nursing assessment managing withdrawal.
So if a patient's last drink was at midnight, when do we expect the neurochemical earthquake to begin?
The onset of withdrawal begins between 4 to 12 hours after the last drink, or even just after a significant reduction in their normal intake.
This is vital for your med-surg rotations. You might have a 60-year-old patient admitted for a total knee replacement. They didn't disclose their heavy drinking history to the anesthesiologist.
And 12 hours post-op, they aren't just in pain. Their blood pressure is 180 over 110, their pulse is 120, and they are sweating through their gown.
You are watching the glutamate storm begin. The subjective and objective findings include coarse hand tremors, profound insomnia, intense anxiety, nausea, and vomiting.
To quantify this storm, we utilize the CIWA-AR scale, the Clinical Institute Withdrawal Assessment for Alcohol, revised.
I love how you describe this to your students.
Yeah, I always tell them that the CIWA scale is like a Richter scale for the nervous system. You aren't just asking if they feel bad, you're measuring the exact magnitude of the autonomic hyperactivity.
Let's walk through it, because the nuance of this assessment dictates whether your patient gets a life-saving medication or goes into a seizure. Let's start with the tremors.
You don't just glance at their hands. You instruct the patient to extend their arms straight out and spread their fingers wide. You are looking for the amplitude.
A score of 0 is no tremor. A moderate score might be a tremor only visible when the arms are fully extended.
But a maximum score of 7 is a severe, constant flapping tremor that occurs even when their hands are resting in their lap.
Then you assess paroxysmal sweats. Are their palms just a little clammy? Or are there obvious beads of sweat on their forehead? A top score means they're experiencing drenching sweats, soaking their sheets.
You evaluate anxiety and agitation, too. Are they simply expressing mild apprehension? Or are they entirely unable to sit still, thrashing about the bed, pacing the room?
Trapped in a state equivalent to an acute, relentless panic attack. And the sensory disturbances are where things get truly dangerous.
You have to ask highly specific questions to assess tactile, auditory, and visual hallucinations, right?
Exactly. You ask, do you feel any numbness, tingling, or like bugs are crawling on or under your skin? You ask, are you hearing noises or voices that you know are not actually there?
And does the light in this room seem uncomfortably bright? Or are you seeing things that are disturbing to you?
Finally, you assess their orientation and cognitive clouding. Can they tell you the date, their location, and who you are? Can they perform serial additions?
You tally the score across all these domains. A score less than 8 indicates mild withdrawal. A score of 8 to 15 is moderate. Anything greater than 15 places the patient in severe withdrawal.
And a severe score means you are staring down the barrel of delirium tremens, the DTs. This is your ultimate safety red flag.
Because untreated or undertreated withdrawal escalates into transient hallucinations, generalized tonic-clonic seizures, and profound cardiovascular collapse.
The DTs usually peak on the 2nd or 3rd day and can last up to a week. If you see this scenario on a board exam or in the emergency department, your instinct might be to focus on their hydration or their anxiety.
Don't fall for it. Your absolute priority is seizure precautions. Safety is non-negotiable.
You ensure the bed is in the lowest possible position, all side rails are up and padded, and you have functional suction equipment and oxygen immediately at the bedside.
You are preparing for their brain to short circuit. Then we fight back with pharmacology. We mentioned benzodiazepines earlier.
We're talking about medications like lorazepam Ativan, chlordiazepoxide Librium, and diazepam Valium.
The logic here goes back to the seesaw. The brain is drowning in excitatory glutamate with no inhibitory GABA to counter it.
Benzodiazepines are potent CNS depressants that bind to the GABA receptors, artificially forcing them open. We are chemically replacing the alcohol with a safer, easily titratable, medically controlled depressant.
To suppress the hyperactivity and stop the seizure before it starts.
We administer these either on a fixed schedule taper where you gradually decrease the dose over several days to gently land the plane, or via symptom-triggered dosing.
Right, where you only push the Ativan when that CIWA score hits a specific threshold, say greater than 8 or 10.
Once the patient safely survives the acute detox phase, the focus shifts to maintaining abstinence. This introduces deterrent medications like disulfiram, known by the brand name Antibuse.
Antibuse is fascinating, and the patient education is critical. It essentially blocks the enzyme aldehyde dehydrogenase.
If a client takes Antibuse and then consumes even a drop of alcohol, acetaldehyde builds up massively in their blood, causing a violent, immediate, and severe adverse reaction.
We are talking intense facial flushing, a throbbing, blinding headache, profuse sweating, and relentless vomiting.
In severe cases, this reaction triggers cardiovascular collapse, respiratory depression, coma, and death.
Which means, as a nurse, you cannot just say, don't drink beer on this medication. You have to turn them into obsessive label readers.
They must avoid all hidden sources of alcohol. That means no liquid cough syrups, no vanilla extract in baking, no alcohol-based mouthwashes.
With vanilla extract.
Yes. And they even have to be careful with alcohol-based aftershaves, perfumes, and hand sanitizers, as it can be absorbed through the skin or inhaled.
Wow. And this extreme sensitivity persists for up to 2 weeks after they stop taking the pill. Contrast that deterrent approach with a medication like acamprosate or Campril.
Acamprosate doesn't make the patient violently ill if they slip up. Instead, it works on the brain's neurobiology to suppress the deep, visceral cravings.
There's a brilliant nuance in how we use these anti-craving meds. Acamprosate is highly effective for what we call relief cravers.
These are patients who are driven to drink primarily to escape the lingering negative physical and emotional misery of early sobriety, like chronic insomnia, restlessness, and free-floating anxiety.
By stabilizing the glutamate system, acamprosate provides relief.
Conversely, a drug like naltrexone is often prescribed for reward cravers, patients whose primary trigger is the memory of the euphoric high, because naltrexone blocks the opioid receptors that mediate that positive reinforcement.
It represents the incredible evolution of addiction medicine. We're no longer just treating a moral failing. We are utilizing targeted pharmacotherapy to address the exact neurobiological driver of the individual's disease.
So, synthesizing everything for alcohol use disorder, if an exam question presents a patient admitted for acute withdrawal who is screaming at you, denying they have a drinking problem, and blaming their spouse for their admission, what is your priority?
Your priority is never to argue with their denial or attempt deep psychosocial therapy while their nervous system is collapsing.
Your priority is to initiate seizure precautions, calculate a CIWA score, and administer a benzodiazepine. Medical stabilization precedes psychological intervention every single time.
That perfectly bridges us into our next massive clinical focus. We are moving from one central nervous system depressant to another, but the acute clinical threat shifts dramatically.
We are moving from the high-voltage danger of alcohol withdrawal to the silent, immediate lethality of an opioid overdose.
The opioid category includes naturally derived prescription analgesics like morphine, semi-synthetics like oxycodone and hydrocodone, illicit street drugs like heroin, and fully synthetic opioids like fentanyl.
Fentanyl is the undeniable driver of the current mortality crisis. It is lipophilic, meaning it crosses the blood-brain barrier almost instantaneously.
And it is estimated to be 50 to 100 times more potent than morphine. A dose the size of a few grains of salt can be lethal to an opioid-naive individual.
The pathophysiology centers on the mu-opioid receptors. When opioids bind to these receptors in the brain, spinal cord, and peripheral nervous system, they profoundly desensitize the user to both physiological pain and psychological distress,
inducing a sweeping, warm euphoria. If you assess a patient who is merely intoxicated on opioids, you will see apathy, profound lethargy, slurred speech, and psychomotor retardation.
They are colloquially nodding off. But the true clinical nightmare, the one you must recognize from the doorway, is the overdose triad.
The overdose triad is a highly testable, classically defining presentation. It consists of 3 pillars: coma, profound respiratory depression, and pupillary constriction, universally described as pinpoint pupils.
Why do the pupils constrict so aggressively? Opioids stimulate the parasympathetic nervous system via the Ettinger-Westphal nucleus in the brainstem, forcing the pupils down to the size of a pinhead.
And simultaneously, those mu receptors in the brainstem's respiratory center are completely silenced. The brain simply stops detecting carbon dioxide levels.
It stops caring that the body is suffocating. You will walk into a room and find a patient who is unresponsive, cyanotic around the lips, with pinpoint pupils and a respiratory rate of perhaps 4 or 6 shallow breaths per minute.
This is respiratory arrest. Death is imminent within minutes if you do not intervene. Your priority nursing assessment is absolute ABCs, airway, breathing, circulation.
Everything else, their history, their psychiatric state, their personal belongings, is irrelevant until that airway is secure and they are ventilating. And the absolute lifesaver here is naloxone, or Narcan.
Naloxone is a pure opioid antagonist. To understand its mechanism, we need to visualize the receptors. I always explain Narcan using the skeleton key analogy.
Let's hear it.
Imagine the mu-opioid receptor as a lock on a door. Fentanyl or heroin are the regular keys. They slide perfectly into the lock, turn, and activate the receptor, causing that massive respiratory depression.
Right.
Naloxone is a skeleton key with an enormous head. When you push IV Narcan, that skeleton key rushes into the brain, violently shoves the fentanyl key out of the lock, and slides in perfectly.
But crucially, it refuses to turn. It does not activate the receptor. And because its head is so massive, it blocks any other fentanyl keys from getting near the lock.
It reverses the respiratory depression and coma almost instantly. You push the Narcan, and a patient who was literally dying seconds ago will suddenly gasp for air, their eyes will fly open, and their pupils will dilate.
And this is the terrifying reality of modern synthetic opioids. The skeleton key has a very short half-life. Naloxone degrades and falls out of the lock much faster than fentanyl leaves the body.
Exactly. The fentanyl is still circulating in their bloodstream, waiting.
The moment the naloxone wears off, often in 30 to 45 minutes, the fentanyl keys rush right back into the receptors. A patient who is awake and talking to you can seamlessly slip right back into a lethal coma an hour later.
You cannot just push Narcan and walk away. You must monitor them continuously, often initiating a continuous naloxone drip for potent synthetic overdoses.
And we also have to prepare for the violent awakening. When you push Narcan, you are throwing them into immediate precipitated withdrawal.
They wake up in agonizing pain, deeply confused, and often highly combative. As a nurse, you administer the drug, step back, ensure the airway is clear, and prepare to de-escalate.
Once the acute overdose is managed, treating opioid use disorder long-term requires significant pharmacological support. This involves medication-assisted treatment, or MAT, to manage cravings and prevent illicit drug seeking.
The classic medication is methadone. Methadone is a potent, long-acting synthetic opiate. It binds to those exact same mu receptors, satisfying the brain's physical dependence and entirely preventing the misery of withdrawal.
But because it has a slow onset and a very long half-life, it does not produce the rapid, intense euphoric high associated with injecting heroin.
Many people struggle with the concept of methadone, arguing that you're simply replacing one addiction with another.
But from a clinical and public health perspective, the transition is vital. You are replacing a dangerous, unpredictable, illegal, intravenously injected street drug with a legal, medically dosed oral medication.
It removes the client from the profound physical risks of IV drug use, like endocarditis and HIV, and extracts them from the criminal environment necessary to obtain illicit substances.
Another major player in EMET is buprenorphine, often combined with naloxone in a drug called Suboxone. Suboxone is an ingenious pharmacological tool.
Buprenorphine is a partial agonist. It binds to the receptor tightly enough to stop cravings and withdrawal, but has a sealing effect so it won't cause respiratory depression in tolerant users.
And the naloxone component is purely a deterrent. If the patient takes the Suboxone film sublingually, as directed, the naloxone is inert. It doesn't absorb well orally.
But if they attempt to melt down the film and inject it to get high, the naloxone instantly activates in the bloodstream, blocking the buprenorphine and throwing them into immediate agonizing withdrawal.
It is a built-in anti-abuse mechanism. We also use non-opioid medications strictly for symptom management during detox. Clonidine is a perfect example.
Clonidine is an alpha-2 adrenergic agonist. It is fundamentally a blood pressure medication. It does not hit the opioid receptors, so it doesn't cure the underlying withdrawal.
But it profoundly suppresses the autonomic overdrive. It dials down the nausea, the vomiting, the explosive diarrhea, and the severe muscle cramps.
Because it is an antihypertensive, your specific nursing consideration is hemodynamics. You must check the patient's blood pressure prior to every single dose of clonidine and hold the medication if they are hypotensive or profoundly bradycardic.
Let's talk about the clinical presentation of opioid withdrawal because it looks completely different from alcohol.
Yeah, you've taught me that while it's rarely lethal, it is deeply miserable.
It is an agonizing full-body experience. As the opioid suppression lifts, the autonomic nervous system wakes up in a state of extreme hyperarousal. The initial symptoms are intense anxiety, restlessness, and a deep, aching pain in the lower back and legs.
I always tell my orientees, if you have a patient with a known history of opioid use, and you see them repeatedly yawning and their eyes are constantly tearing up lacrimation and their nose is running like a faucet rhinorrhea, do not assume they just caught a cold.
That triad of yawning, tearing, and runny nose is the absolute classic onset of the opioid withdrawal timeline.
From there, it escalates to severe gastrointestinal distress, piloerection goosebumps, which is where the term quitting cold turkey comes from, fevers, and profound dysphoria.
For short-acting drugs like heroin, this agony peaks in 2 to 3 days and gradually subsides over a week to 10 days.
So what is the exam trap here? If you're faced with a scenario on a board exam where a patient is found unresponsive with a respiratory rate of 6 and pinpoint pupils, one of the answer choices will inevitably be about establishing a therapeutic alliance or exploring their reasons for relapse.
Do not fall for it. Psychosocial interventions are meaningless if the brain is deprived of oxygen. Naloxone and airway management are always your first immediate actions.
Which perfectly underscores the overarching theme. Central nervous system depressants are lethal, but the mechanism of their lethality varies. This brings us to the hidden killers, prescription sedatives, hypnotics, and anxiolytics.
We are talking about medications like barbiturates, such as phenobarbital or secobarbital and benzodiazepines.
While the opioid epidemic commands the headlines, these prescription pills are silent, deadly cousins. They behave very similarly to alcohol. They are profound CNS depressants that modulate the GABA system.
The expected findings for intoxication mirror alcohol perfectly. Slurred speech, profound lethargy, impaired coordination, and stupor. But there is a massive, highly testable difference in the safety red flags when we compare an overdose of benzodiazepines to an overdose of barbiturates.
This is a critical distinction. If a patient takes a massive oral overdose of a benzodiazepine like Xanax or Valium by itself, they will be profoundly lethargic, highly confused, and they will sleep for a very long time.
But, remarkably, they will rarely die from it. Benzodiazepines require endogenous GABA to work. They increase the frequency of the ion channels opening, but they have a biological ceiling effect.
Barbiturates, on the other hand, have no such ceiling. Barbiturates increase the duration of the channel opening.
And at high doses, they can force the chloride channels open entirely on their own, independent of the body's natural GABA. Therefore, a barbiturate overdose is highly lethal.
It will rapidly induce a deep coma, complete respiratory arrest, cardiovascular failure, and death.
If a patient presents with a barbiturate overdose, the priority interventions are aggressive. We are talking about potential gastric lavage, physically pumping the stomach, if ingestion was recent administering activated charcoal to bind the drug in the gastrointestinal tract.
And in severe toxicity, initiating hemodialysis to physically scrub the drug out of their bloodstream while providing mechanical ventilation.
And just like alcohol, the withdrawal danger from these drugs is severe autonomic hyperactivity. The symptoms are the exact opposite of the drug's intended therapeutic effect.
Instead of sedation and anxiety relief, the nervous system rebounds into hyperalertness, profound insomnia, extreme tremors, a soaring heart rate, and critically, seizures.
The absolute life-or-death nursing logic here revolves around tapering. You will see this tested repeatedly.
If a patient has been taking high sustained doses of a barbiturate or a benzodiazepine for months, the intervention is never, ever to stop the medication cold turkey.
Abrupt cessation of a barbiturate will hurl the patient into status epilepticus, coma, and death. Tapering, administering meticulously decreasing doses over weeks or months is a physiological necessity.
Let's pivot the entire physiological mechanism now. We have thoroughly explored the downers. We need to examine what happens when the central nervous system is chemically pushed into extreme overdrive, or when the perception of reality is radically distorted.
We are looking at stimulants, hallucinogens, inhalants, and cannabis.
Let's start with the central nervous system stimulants, primarily methamphetamine and cocaine. The expected findings here are the exact inverse of opioid intoxication.
You will assess severe tachycardia, dangerously elevated blood pressure, widely dilated pupils, hypervigilance, rapid pressured speech, and grandiose, often paranoid delusions.
To understand why, you have to look at the neurotransmitter cascade. Methamphetamine, for example, is a catastrophic drug for the brain.
It doesn't just mimic dopamine. It forces the neurons to dump massive, unholy amounts of dopamine and norepinephrine into the synapses, and then it actually reverses the reuptake transporters, trapping those excitatory chemicals in the brain.
It is a flood of artificial energy and euphoria that pushes the cardiovascular system to the breaking point. The safety red flags for stimulant overdose are hypertensive crisis, ischemic strokes, myocardial infarctions, hyperthermia, and drug-induced seizures.
The body is literally running an engine at 10,000 RPMs without any coolant until it detonates. Methamphetamine abuse also causes profound, often permanent structural brain damage and deep psychotic behavior that mimics paranoid schizophrenia.
But the unique nursing priority emerges during the withdrawal phase. With stimulants, we don't call it a withdrawal syndrome, we call it a crash.
Because the brain has been entirely depleted of its dopamine stores, and the receptors have violently downregulated to try and survive the flood, when the meth is gone, the brain physically cannot experience pleasure.
The crash occurs within hours to days and is characterized by marked, crushing dysphoria, overwhelming fatigue, increased appetite, and psychomotor retardation.
Unlike alcohol or opioids, there is no pharmacological detox protocol for stimulants. There is no methadone for meth. The danger is not physiological collapse. The highest risk during a stimulant crash is suicide.
That is your nursing priority. The profound chemical depression and absolute anhedonia can easily lead to lethal suicidal ideation.
Your assessment shifts entirely from preventing a seizure to instituting rigorous safety protocols, one-to-one observation, and preventing self-harm until their brain chemistry slowly begins to regenerate.
Let's move to hallucinogens, specifically looking at substances like LSD and PCP. These drugs radically distort reality, cause severe depersonalization, and trigger hyperreflexia.
For most hallucinogens, like LSD or psilocybin, the toxic reactions are primarily psychological. The patient is experiencing a terrifying bad trip, severe panic, or paranoia.
The standard evidence-based nursing intervention is talking down the patient. You bring them to a quiet space, you speak in a calm, highly reassuring voice, and you continuously orient them to reality.
Reminding them that the terrifying visions they are seeing are just the temporary effects of a drug and that they are safe.
But there is a massive critical exception to that rule, and it is phencyclidine, or PCP.
PCP is a dissociative anesthetic. It acts as an NMDA receptor antagonist, effectively disconnecting the cerebral cortex from the sensory input of the body.
A patient intoxicated on PCP literally cannot process pain, and they cannot process reason. They exhibit extreme belligerence, unpredictable explosive aggression, profound impulsivity, and they often display what looks like superhuman strengths because their pain inhibitors are entirely offline.
PCP toxicity can also cause lethal hyperthermia and status epilepticus. If you attempt to use the standard hallucinogen protocol, if you try to step into their space and talk down a patient on PCP, you will likely provoke a violent attack.
You do not try to reason with PCP intoxication. Your priority is absolute safety and containment.
They require immediate isolation in a room with minimized external stimuli. Physical restraints may be an absolute necessity for the safety of the client and the staff.
And chemical restraints, administering antipsychotics like Haldol or benzodiazepines like diazepam, are often required to control the explosive behavior and prevent seizure activity. It's a completely different protocol.
Which highlights how crucial drug-specific knowledge is. Now let's briefly touch on inhalant substances like gasoline, glue, paint thinner, and aerosol propellants.
These are often used by very young adolescents due to their easy accessibility. The intoxication findings include severe dizziness, stupor, and notably nystagmus, that involuntary rapid twitching of the eyes.
The mechanism behind the nystagmus is actually devastating. These industrial solvents are highly lipophilic. They dissolve fat. The human brain, particularly the myelin sheaths that insulate our neurons, is largely composed of fat.
Inhaling these solvents essentially dissolves the myelin in the cerebellum and the vestibular system, causing the eyes to completely lose their smooth tracking ability.
The acute safety red flags for inhalants are sudden sniffing death syndrome, which is fatal cardiac arrest caused by sudden catecholamine release, bronchospasm, suffocation, or aspiration of vomitus while unconscious.
Long-term, these solvents cause persistent, entirely irreversible dementia and profound peripheral nervous system damage. There are no antidotes. You provide immediate advanced cardiac life support and respiratory support.
Finally, in our substance overview, we must discuss cannabis.
The expected findings for acute cannabis intoxication are well known. Impaired motor coordination, conjunctival injection, bloodshot eyes, dry mouth, and an increased appetite.
Clinically, while fatal overdose is virtually non-existent, the exam logic focuses on recognizing intoxication and managing a relatively new, highly specific phenomenon, cannabis hyperemesis syndrome.
We are seeing this increasingly in emergency departments, particularly among heavy users of the extremely high-potency THC concentrates available today. Cannabis hyperemesis syndrome causes cycles of severe, intractable, violent vomiting and abdominal pain.
Interestingly, patients often learn that taking compulsively hot showers or baths temporarily relieves the symptoms, which is a key diagnostic clue for the triage nurse.
And as a professional note, while the legal and political landscape surrounding marijuana is rapidly shifting across different states, nursing practice remains anchored strictly in clinical reality.
We remain politically neutral. Our sole focus is assessing and treating the physiological and psychological effects of the substance on the human being sitting in front of us.
Which brings us to the most vital skill a psychiatric nurse possesses. Once a patient survives the terrifying physiological gauntlet of withdrawal, how do we actually talk to them to promote long-term recovery? This is the therapeutic milieu in communication.
The rules of therapeutic communication in addiction medicine are incredibly specific. You must act as a compassionate yet immovable mirror. Let's outline the precise do's and don'ts.
The do's. Be completely matter-of-fact in your tone. Always redirect the client back to their own problems and their own choices. Keep the focus relentlessly on the here and now.
Encourage the open expression of their feelings and utilize role play to help them navigate difficult interpersonal situations without resorting to substance use.
And the absolute don'ts. You do not argue with the patient. You do not allow them to build complex rationalizations.
And under no circumstances do you allow the client to blame external circumstances, other people, their job, their childhood, for their decision to use a substance today.
Let me give you a classic clinical scenario. You are running a group therapy session. A client sits down, crosses his arms, and says, "Look, my wife is constantly nagging me. Nothing I do around the house is ever good enough for her. We fight all the time, and that tension is why I have to drink to calm down."
If I am a novice nurse, my human instinct might be to validate his frustration and say, "Wow, it sounds like your wife shouldn't nag you so much."
If you say that, you have instantly failed as a therapeutic agent. By validating his external blame, you have enabled his rationalization.
You have given his disease permission to continue because you agreed that his drinking is his wife's fault.
Exactly. Instead, a skilled psychiatric nurse shifts the locus of control entirely back to the patient. You look at him and ask, how do you choose to communicate with your wife when you feel frustrated?
Or, what coping mechanisms can you employ when the tension in your house rises? You are dismantling the excuse.
You are forcing the patient to examine their own internal behavior, rather than focusing on the external events they cannot control. This precise dynamic bleeds directly into our assessment of the family unit, specifically looking at codependence and enabling.
A prolonged relationship with a person actively using substances breeds severe maladaptive coping patterns in their loved ones.
Codependent individuals often exhibit poor relationship skills, exist in a state of excessive, chronic anxiety, and engage in compulsive behaviors designed to control the addict's environment.
A very specific, highly destructive subset of codependence is enabling. Let's look at a textbook enabling scenario.
A husband goes on a massive alcohol bender on a Sunday night. Monday morning, he is hungover, shaking, and cannot get out of bed. His wife calls his boss and lies, saying he has a severe stomach bug and can't come to work.
On the surface, the wife believes she is being intensely helpful and loving. She is protecting his career, which protects their family income.
But clinically, she is actively feeding his disease. By shielding him from the negative consequences of his bender, she prevents him from facing the true, devastating implications of his illness.
The disease thrives in that protected environment. It guarantees the cycle will continue because the addict never feels the burn of the fire they started.
And we have to be incredibly vigilant because nurses are highly susceptible to becoming enablers.
If you have a patient who is perfectly capable of completing their own activities of daily living, but you feel sorry for them and do everything for them, making excuses for their lack of participation, you are no longer treating them. You are enabling their helplessness.
We also have to tackle one of the most complex clinical challenges on a psychiatric floor, the dual diagnosis. This occurs when a client is battling an active substance use disorder while simultaneously managing a severe, chronic, major psychiatric illness.
The overlap is staggering. Clinical data suggests that up to 75% of individuals living with severe, persistent mental illnesses like schizophrenia, severe bipolar disorder, or severe major depressive disorder also struggle with a co-occurring substance use disorder.
Treating a dual diagnosis requires extreme clinical finesse because the traditional models of addiction recovery often directly clash with psychiatric realities.
Think about it. Let's say you have a patient with paranoid schizophrenia who has been self-medicating their terrifying auditory hallucinations with illicit methamphetamines.
Now they're in recovery. The traditional 12-step program model demands absolute, rigid abstinence from all psychoactive or mind-altering drugs.
But that schizophrenic patient must take highly potent, mind-altering psychotropic medications like a daily dose of a second-generation antipsychotic simply to survive and maintain a grip on reality.
The messaging is incredibly confusing for them. Furthermore, patients with severe psychiatric illnesses, particularly schizophrenia or deep depression, often suffer from significant cognitive impairment.
They have a severely reduced capacity to process abstract concepts. The 12-step model relies heavily on highly abstract philosophical ideas surrendering to a higher power, conducting a sweeping moral inventory, and committing to lifelong, permanent abstinence.
A patient battling acute psychosis or crushing mania cannot process the concept of forever. They cannot grasp a higher power when their own brain is actively lying to them.
They require highly concrete, immediate interventions. As the nurse, you don't ask them to promise they won't drink for the rest of their lives.
You give them robust, positive feedback for maintaining abstinence just for today. You focus on the next 24 hours, and you must rigorously assess their unstructured time.
Excessive free time is a massive trigger for relapse, particularly when a patient is dealing with the negative symptoms of schizophrenia, like apathy and lack of motivation.
The intervention is highly concrete. You sit down with a client, and you physically write out a daily schedule of purposeful activities on a paper calendar. You structure their day hour by hour.
8:00 a.m. breakfast, 9:00 a.m. recreation. You remove the void of free time where the urge to use festers.
If you encounter a dual diagnosis question on a board exam, the correct therapeutic response will always be the one that provides concrete, immediate structure and holds the client accountable in the present moment without using guilt or punitive measures.
We are moving into our final and perhaps most uncomfortable clinical focus. We have spent this entire deep dive analyzing how substance use destroys patients and shatters their families.
But we must turn the lens inward. We have to discuss the impaired professional.
It is a dark, sobering reality of our profession. The data clearly indicates that healthcare providers, specifically primary care physicians, dentists, and registered nurses, have vastly higher rates of dependence on controlled substances, such as opioids, high-grade stimulants, and potent sedatives, than other professionals with comparable levels of education.
The driving factor is access. We possess the keys to the narcotic cabinet. We administer fentanyl, morphine, and Ativan every single shift. We know exactly what these drugs do, and we harbor a dangerous hubris.
Nurses often rationalize their diversion. They think, I have a chronic back injury from lifting patients. I know the pharmacology. I know exactly how much Dilaudid I can take to relieve the pain without stopping my breathing. I can control this.
But the disease of addiction does not respect your nursing degree. And alongside the access, the relentless stress, burnout, and emotional trauma inherent in the nursing profession lead to significantly higher rates of alcohol use disorder compared to the general population.
Because it is happening right next to us at the nurses' station, we must be experts at identifying the warning signs and red flags of an impaired colleague. And it is rarely as obvious as a nurse staggering down the hallway or slurring their speech.
High-functioning professionals are masters of camouflage. The signs are usually subtle shifts in workflow. You must look for persistent anomalies. Are there constantly incorrect narcotic counts when they are on shift?
Is there an excessive amount of controlled substances being listed as wasted, dropped, or contaminated by this specific nurse?
Here is the most chilling, heartbreaking red flag of all. Are the patients assigned to this nurse consistently complaining of ineffective pain relief?
If a patient was comfortable on 2 milligrams of IV morphine yesterday, but today, under this nurse's care, they are writhing in agony after supposedly receiving the same dose, you must be highly suspicious.
The nurse is likely pocketing the pill, or worse, siphoning the IV narcotic for themselves and injecting the patient with plain saline.
Other behavioral cues include finding damaged, glued, or torn tamper-evident packaging in the medroom. Notice if the nurse consistently makes immediate trips to the private staff bathroom right after pulling a narcotic from the pizzas.
Look for unexplained frequent absences from the unit or a pattern of consistently arriving to shift very early or staying very late for no justifiable clinical reason.
So let's put you in the hardest scenario imaginable. You are on a busy med-surg shift. You are working alongside your best work buddy. You've known this nurse for 5 years. They are a fantastic clinician, and they covered your shifts when your kids were sick.
But today, they're acting incredibly erratic. They are sweating. They've made 3 extra trips to the narcotic lockbox, and one of their post-op patients is crying in agony, claiming their pain medication didn't do anything.
You know what is happening. Should you pull your buddy aside into an empty supply closet, tell them you know what's up, and give them a stern warning to get their act together before management catches them?
The answer is an absolute unequivocal no. The ethical and legal guidelines are crystal clear. You do not handle this privately, you do not intervene alone, and you absolutely do not warn the coworker.
It feels like a massive betrayal of a friend. Why is warning them so wrong?
Because confronting them privately accomplishes nothing but enabling the disease. If you warn an impaired professional, you are simply giving them a heads up that their camouflage is slipping.
They will not magically stop using. They will just find a more secretive, potentially more dangerous way to divert the drugs. Or they will transfer to another unit and continue the abuse.
Furthermore, you are bound by an uncompromising ethical and legal obligation, defined explicitly in your state's Nurse Practice Act, to report any suspicious behavior directly up the chain of command to a nursing supervisor, a charge nurse, or a unit manager.
Ignoring the signs or trying to protect your friend fundamentally endangers the public. If that impaired nurse pushes the wrong medication, ignores a critical vital sign, or causes a fatal sentinel event because their cognitive function was compromised, and you knew about their impairment but remained silent,
You are complicit in that failure of patient safety. You have violated the core tenet of the nursing profession.
If you face this scenario on the NCLEX, the exam logic is foolproof and unyielding. The answer choice might try to tempt you with assess the nurse for signs of stress or confront the colleague privately to preserve unit morale. Do not click those answers.
If you suspect impairment, the only correct action is report the observation directly to the nursing supervisor. Period. Never confront, never ignore.
It is the ultimate test of prioritizing patient advocacy over personal comfort.
This has been an incredibly intense journey through the jungle of substance use disorders. We have covered a massive amount of clinical ground, but I believe we've carved a very clear logical path. Let's run a rapid-fire summary of the absolute highest yield takeaways to lock this in.
For opioid overdoses, prioritize ABCs and prepare for continuous naloxone administration due to its short half-life. For acute alcohol withdrawal, your priority is immediate seizure precautions and the administration of benzodiazepines to suppress the glutamate storm.
Push thiamine to protect the brain from irreversible Korsakoff psychosis, and in every interaction, utilize direct, matter-of-fact therapeutic communication that demands patient accountability in the present moment.
And as we wrap up this deep dive, I want to leave you with a final thought circling all the way back to how we started. We talked about how the X-ray machine doesn't work in psychiatric nursing.
We talked about how the diagnostic landscape is murky and requires intense perceptive assessment. Throughout this entire discussion, we have focused on looking outward. We use the CIWA scale, we monitor pupillary responses, we track respiratory rates.
We spend 12 grueling hours a shift scanning the horizon for the subtle signs of dependency and withdrawal in the vulnerable people we care for.
But the reality of the impaired professional forces us to turn that incredibly sharp assessment tool around and look in the mirror. Nurses are highly susceptible to the exact same neurobiological hijacking as the patients sleeping in our beds.
So here's the provocative question I want you to take with you on your next clinical rotation or your next grueling night shift. When was the last time we truly turned that assessment inward?
When did we last look closely at the crushing burnout, the emotional trauma, and the sheer overwhelming access to narcotics that puts our own colleagues at such massive risk?
If we can find the compassion and the clinical logic to treat our patients with a true disease model approach, understanding that addiction is a powerful physiological and genetic vulnerability and absolutely not a moral failing, can we find the courage to apply that exact same grace and that exact same vigilant, life-saving assessment to the nurse standing quietly next to us at the medication cart?
That is where rote memorization ends, and true clinical judgment and profound human compassion begin. Take that perspective with you into your next exam and, more importantly, onto the floor. Keep your patients safe, keep your colleagues safe, and keep carving that path. See you next time.